Hello, and welcome to the first installment of our How I Practice videos on metastatic urothelial carcinoma. I'm Dr. Tian Zhang. I'm an associate professor and director for clinical research in the Department of Medicine at UT Southwestern in Dallas, Texas. And I'm joined by my colleague, Dr. Petros Grivas, a great friend and professor in the clinical research division at Fred Hutch Cancer Center and also in the Department of Medicine at the University of Washington in Seattle, Washington.
Thank you so much, Dr. Zhang. Great to work with you, and thanks for having me today.
Always a pleasure, Petros. Over the next few months, we'll be posting a series of these short CME certified videos focused on the management of patients with advanced and metastatic urothelial carcinoma. If you haven't already completed your pre-survey, please do so by clicking the link below this video or by scanning the QR code shown here. Let us know who you are in the polling questions below. Also, please be sure to complete your evaluation at the end of the session and claim your CME credits. This activity is jointly provided by PACE and Bonum CE, and this program has been supported by educational grants from Astellas, Gilead, Merck, and SeaGen. Over the coming weeks, be sure to watch our handles for an additional bladder cancer CE programming and follow at Bonum CE for more CME certified programs on Twitter. Here's a look at our disclosures. And today we will be describing the efficacy data regarding immune checkpoint inhibitors and other approved drug classes, including the use of maintenance therapy in metastatic urothelial cancer, and selecting appropriate treatments based on the latest recommendations from the NCCN preferred treatment regimens for metastatic urothelial cancer. And with that, let's kick it off. So here today, we'll be talking about that treatment landscape for metastatic urothelial cancer, which has been rapidly evolving. But first, we'll talk about what's new in the adjuvant treatment for urothelial cancer by introducing a patient case. So here's our patient. Ed is a 75-year-old man who is a former smoker with no family history of cancer. He was diagnosed with an upper tract urothelial carcinoma, clinical stage CT3 and XM0. And shortly after diagnosis, he underwent a radical nephroureterectomy and a lymph node dissection without any major complications. On pathology, his stage was pathologic T3 and 2 disease with nodal involvement. And 7 weeks after surgery, he began adjuvant chemotherapy with cisplatin and gemcitabine following negative restaging imaging. His medical history is listed here with a normal creatinine clearance at 60 mils per minute. And so what is our ongoing treatment in the adjuvant setting for patients like Ed? Petros?
Thanks, Tian. So very important to reflect about the current data we have in the adjuvant setting. We have data in the adjuvant setting for upper tract urothelial carcinoma, and the large phase 3 trial came from UK called the POUT trial, and we just got updated data from the long-term follow-up. Very briefly, this was a phase 3 trial randomized, open label, including 261 patients with upper tract urothelial carcinoma who had radical nephroureterectomy, and after that, they were randomized to adjuvant platinum-based chemotherapy. Most patients got gem-cis. A few of them got gem-carbo if they were ineligible for cisplatin based on GFR, or surveillance. And that trial was positive. The 5-year disease-free survival rate was 62% with adjuvant platinum gemcitabine versus 45% with surveillance alone. And this gave a hazard ratio of 0.55, significantly favoring adjuvant platinum-based chemotherapy. If we look at the overall survival, the trial stopped because of the DFS benefit, and it was not fully powered to show an overall survival benefit. Despite being underpowered, the 5-year overall survival rate was 66% with platinum-based chemotherapy versus 57% with surveillance. The hazard ratio was 0.68, and there was no UTUC signal. So overall, I would say, although overall survival was not the primary endpoint, I think the updated data from the POUT trial, I think, strongly support the use of adjuvant platinum-based chemotherapy. I feel strongly about cisplatin in cisplatin-eligible patients. I think there are still questions, Tian, about adjuvant carbo-gem because it was a smaller subset of those patients, smaller sample size, meaning lower power, wide confidence interval. So there is an uncertainty with adjuvant carbo-gem. I still discuss it with the patients who are cisplatin ineligible, and I have discussion about pros and cons. the benefit we see in POUT and potential toxicities and help the patient decide. Very briefly, I want to comment that we have clinical trials with adjuvant checkpoint inhibitors. And two of those trials, the adjuvant nivo and the adjuvant pembro, included a small proportion of patients with upper tract disease. And my take on it is that this small subset of upper tract patients are too small to derive any conclusions. So I think there is still uncertainty about adjuvant checkpoint inhibitor in the upper tract disease. Having said that, the subset of patients with upper tract urothelial tumors, there is a very wide confidence interval, but this merits discussion with the patient because adjuvant nivolumab for now has FDA approval in the adjuvant setting, and that includes upper tract disease based on the SegMed-7/4 trial as of August 2021. We see many patients who, after neoadjuvant therapy or de novo, may present with metastatic disease. And the question is, how do we treat those patients? So I would like to present the case here. 75-year-old gentleman, former smoker, that we talked about, no family history of cancer. It's always good, by the way, to review family history with the patients in the broader family because we see a lot of germline mutations. This patient received gemcitabine cisplatin based on the POUT phase 3 trial, and the scan that was performed 3 months after completion of adjuvant chemotherapy sadly showed metastatic disease. So this was a platinum refractory case with a very short progression after completion of adjuvant chemotherapy. These scans showed mediastinal and retroperitoneal and lymphadenopathy, also a couple of lung nodules consistent with cancer progression. This patient overall has been fit, still has an ECOG PS1, and the question is, what do we do in that patient in this particular setting? What will be, Tian, your thinking process here about managing these patients when very early progression was noted soon after adjuvant gem-cis?
Sure. I think, it's not an uncommon situation, unfortunately, in our clinics. Fortunately, we actually saw some really great data at ESMO 2023 about combining agents that we've had as monotherapies for metastatic urothelial cancer. So enfortumab vedotin in combination with pembrolizumab, we saw that in a large randomized phase 3 trial showing significant benefit. And so in a patient like this who is progressing pretty quickly after adjuvant chemotherapy, I think would be a good setup to consider EV with pembro, particularly since he is otherwise functionally fit and doing well to receive more treatment. So let's go over a little bit of the data from EV302. This was a randomized global phase 3 trial with enfortumab vedotin and pembrolizumab. Here we're showing the progression-free survival data. As you can see, the median progression-free survival improved from 6.3 months with gemcitabine with platinum to 12.5 months with enfortumab vedotin and pembrolizumab. This hazard ratio was 0.45 and was statistically significant. In addition, on overall survival, we also saw an impressive improvement from 16.1 months with chemotherapy to 31.5 months median overall survival with enfortumab vedotin and pembrolizumab. Here, the hazard ratio was 0.47, and again, statistically significant, and I would say also clinically significant for our patients to see this type of benefit. Of note, the objective response rates for enfortumab vedotin with pembrolizumab was 67.7%. This included 29.1% complete responses, and I think that's really important when we're thinking about these patients because the hope is that some of these complete responders continue to have durable responses over time. And this is compared against about 44% objective responses in patients treated with chemotherapy. And if we look at median duration of response too, it was not reached for the patients treated with enfortumab vedotin and pembrolizumab compared to about 7 months for patients treated with chemotherapy who received a response. There were grade 3 and higher treatment-related adverse events in about 56% of patients treated with enfortumab vedotin and pembrolizumab versus about 70% of patients treated with gemcitabine with a platinum-based chemotherapy. The skin reactions and neuropathies are pretty common, and we watch in particular for those over the course of time. The neuropathy tends to build up over the treatment cycles, and also hyperglycemia was a treatment adverse event of interest, around 6% for patients treated with EV and Pembro. Otherwise, the severe skin reactions were about 11.8%, and this is compared against the common grade 3 and higher treatment-related adverse events for chemotherapy, of which the cytopenias were the most common, so anemia, neutropenia, and thrombocytopenia. And so with that, enfortumab vedotin and pembrolizumab was fully approved by the US FDA on December 15th, 2023 for frontline treatment, regardless of cisplatin eligibility, based on these results that we just discussed. It is the new preferred standard of care as frontline therapy for metastatic urothelial cancer. The NCCN guidelines were updated, and EV and Pembro is now listed as a preferred regimen for cisplatin eligible patients. Another number of patients may not be ideal candidates for EV and pembrolizumab. Patients that come to mind could have peripheral neuropathy, more than grade 2 at baseline. They could have poorly controlled diabetes, where you don't want them to incur the risk of hyperglycemia. Patients with liver cirrhosis or high degrees of dysfunction, liver dysfunction, may not be optimal candidates. And also patients with active ongoing autoimmune disease, where you're concerned where pembrolizumab may reactivate or worsen their autoimmune disease. These patients may not be good candidates for the combination. Petros, speaking of patients who may not be potential candidates for enfortumab vedotin and pembrolizumab, what are your other preferred treatment options for frontline management of metastatic urothelial cancer?
Thanks, Tian. Great overview, and really impressive to see this data in urothelial carcinoma. So much has been changing. It's really, really impressive to see the transformative data presented at ESMO 2023 and all the recent updates in the last 8 years, I would say, in this disease. On June 30th, 2020, the avelumab maintenance immunotherapy was FDA approved for the treatment of patients who had either a response or stable disease to platinum-based chemotherapy in the frontline setting of advanced urothelial carcinoma. So those patients with no progression, they got avelumab versus observation, again, as a switch maintenance approach. And you see in that trial that there was a significant overall survival and progression-free survival benefit with avelumab switch maintenance. And we saw that with longer follow-up, the hazard ratio for overall survival favoring avelumab maintenance was initially 0.69, and with longer follow-up, 0.76, mainly because many patients in the control arm, by supportive care alone, they went on to get subsequent therapies. Having said that, there's still a significant PFS-OS benefit with avelumab switch maintenance immunotherapy, again, for those patients who did not progress, who had response or stable disease to platinum-based chemotherapy, gem-cis or gem-carbo in the frontline setting. And the 3-year overall survival, about half of the patients who received avelumab maintenance are alive in 3 years. Definitely an improvement compared to what we used to see before the establishment of maintenance avelumab immunotherapy. Now, what other regimens we can think of? We just talked about maintenance avelumab if the patients have platinum-based chemotherapy as induction and they had response to stable disease. The second trial that I think is relevant is the CheckMate 901 trial. Similar to the avelumab maintenance trial, this is an effort to add checkpoint inhibition, not as a sequential approach, maintenance approach, in JAVELIN, but as a concurrent approach. So this is gem-cis plus nivolumab versus gem-cis alone. And the gem-cis nivolumab arm had the concurrent nivolumab and maintenance of nivolumab for up to 2 years, assuming there was no progression or significant toxicity. And that trial showed a significant PFS and overall survival benefit. Hazard ratio was, I think, 0.72 for PFS, 0.78 for OS, favoring gem-cis nivo over gem-cis. Interestingly, only 20% of patients in the chemotherapy gem-cis alone arm received maintenance avelumab. And the question was, if that proportion was higher, if more patients got maintenance avelumab in the control group, would that potentially may have resulted in a negative CheckMate 901 trial? It's hard to tell, but it's a question. So the question about concurrent nivolumab remains questionable. Having said that, the response rate is higher with gem-cis nivo versus gem-cis, so you get more patients to respond, and I think that's relevant for the decision making for patients. The response rate was 58% with the gem-cis nivo versus 43% with gem-cis, and you see that about 22% of patients with gem-cis nivo achieve a complete response, and the median duration of this complete response was 37 months. So if you achieve a CR with gem-cis nivo, the chance of maintaining that is high, at least based on this data. The problem is we don't know, who are those patients, right? And how can we predict? We lack biomarkers to predict who these patients with complete response are. Having said that, because of the data that we just quoted, I think gem-cis nivolumab is another very reasonable option, and many patients may opt to get the IO upfront because of the higher response rate and the lower primary progression rate. Of course, the toxicity profile can be impacted if you give immunotherapy up front, but the combination of chemotherapy and immunotherapy seems to be feasible. There was no new toxicity signal, and the toxicity profile was as expected if you add a checkpoint inhibitor with chemotherapy, with immune-related adverse events being a risk there. It's interesting to see these changes, and the big question, Tian, is what happens in the second-line setting, right? We've seen incorporation of checkpoint inhibition in the front-line setting in all of those three trials, right? EV302, CheckMate 901, JAVELIN Bladder 100. What are we doing second-line, right? That's a big question, I think.
Absolutely, especially as our active agents, right, are moving earlier and thinking about treatment sequencing and disease resistance. I think all of those are active questions, and we're still certainly all of us are grappling with these issues as they come up in our clinical practices. I think these are an evolving picture as new data become available. I think patients who are cisplatin eligible, who are chemo naive, those people coming off of EV and Pembro, for example, those patients are recommended to have cisplatin-based chemotherapy, or if they have FGFR alterations, to have erdafitinib from the updated NCCN guidelines. And I think those are very solid options after enfortumab, vedotin, and pembrolizumab. Pembrolizumab alone is still a preferred second-line option for people who are checkpoint inhibitor naive, who have received frontline platinum-based chemotherapy per the updated NCCN guidelines. Although enfortumab vedotin could also be given as a second-line therapy for patients who are ineligible for cisplatin. That's based on a trial that has been now published a few years now, enfortumab vedotin EV201 trial. And in addition, I think selection of those salvage treatments would depend on many of the patient factors. For example, their performance status, medical comorbidities, their organ function, level of evidence of the treatment options available, as well as the efficacy and toxicity profiles, prior treatments, sites of metastasis, et cetera. And I think early sequencing of their tumors to help us make those treatment decisions is really important as we start separating patients out in terms of what they might respond to. So Petros, can you tell us a little bit more about these newer agents? So in particular, erdafitinib and sacituzumab govitecan, and how they're fitting into your treatment landscape at this point?
Excellent, Jan, for sure. And, there's so much data as we discussed. And erdafitinib is the first targeted therapy that received FDA approval in a selected patient population in advanced urothelial carcinoma. The accelerated approval came back in April 2019, about 5 years ago, based on the BLC 2001 trial, phase 2 trial with erdafitinib single agent monotherapy in patients who had progression on platinum-based chemotherapy. This was an about 100-patient study, not randomized. And because of the response rate, that it was about 40%, in the historical context, data with taxane, for example, FDA gave accelerated approval to erdafitinib and said, let's do a phase 3 trial to confirm the data from the BLC 2001 phase 2. The phase 3 trial was reported at ASCO by Dr. Loriot in 2023, and this was the THOR trial. It was a trial comparing in randomized fashion erdafitinib, an FGFR inhibitor, versus docetaxel or vinflunin, docetaxel in the US, vinflunin in Europe, in patients who have received prior immunotherapy. About 90% of those patients had also received platinum-based chemotherapy. So it's interesting because when we think about the sequence of those agents, someone can argue you can give erdafitinib, before platinum, and that's reasonable based on THOR, but 90% of patients had prior platinum. So vast majority of them had platinum before erdafitinib. That's just something to keep in mind. Now, the data from the THOR cohort 1 particularly showed a significant overall survival benefit. I think the hazard ratio was 0.64, favoring erdafitinib. Median overall survival, 12 months versus 8 months, favoring erda. And also you saw a doubling of the median PFS and a significant increase in the response rates, about 45% with erdafitinib and only about 12% with docetaxel and vinflunin. So overall, there was a significant improvement in all endpoints by erdafitinib. This is only in selected patients based on the presence of a tumor having an FGFR3 mutation or fusion. Not amplification, but an FGFR3 activating mutation or fusion rearrangement that may drive the tumor. And this is present approximately in 20% of patients with metastatic urothelial carcinoma. It's probably about 15% in metastatic bladder cancer and about 30% in metastatic upper tract urothelial cancer. So it's very important, as Tian, you mentioned, to do tumor genomic sequencing at the time of diagnosis of metastatic disease, for sure, in order to have the data results available and evaluate erdafitinib as a potential FDA-approved option after at least one prior line of therapy. And the FDA recently updated the label of erdafitinib and gave a regular approval, full approval to erdafitinib in patients who had at least one prior line of therapy. And that line of therapy ideally should contain immunotherapy. If not, patients should receive immunotherapy before erda, unless there is a contraindication to immunotherapy. For example, active autoimmune disease on steroids, for example, someone can argue you can go to erda first. Now, there always this discussion about the optimal sequence. And I don't think, as I mentioned before, we know if we need to give platinum before erda or no. That's an open question. But at least in the third cohort 1, vast majority of patients got prior IO or prior chemotherapy. The other important comparison was in platinum refractory patients. For cohort 2 compared erdafitinib to pembrolizumab, platinum refractory disease. Patients had progression, could not get maintenance avelumab. That trial was published in 2023, and overall there was no significant difference in OS or PFS between erda and pembro. Having said that, you see a high response rate with erdafitinib, 40% versus 22% with pembro. So high response rate with erda, but more durable responses with pembro. You are more likely to respond with erda, but if you respond with pembro, this may last longer. And that's why there was no difference in overall survival or PFS. I think if you want to achieve a response right away, visceral metastasis, high symptomatic burden, high cancer burden, erdafitinib looks very compelling in that sense. Obviously, the label as it is right now by the FDA, you probably have to give immunotherapy before, at least in patients with no contraindication. And if patients get pembro EV first line, the question is, what do you do second line? You do carbogem or in cisplatin-eligible patients or erda, and that's, I think, a very open question that needs to be defined, in the real world. Now, sacituzumab govitecan, that's an antibody-drug conjugate against TROP2, carries a payload against topoisomerase 1. It's a topoisomerase 1 inhibitor. It's called SN38, the metabolite of irinotecan. And that TROP2 antibody is linked to this SN38, the topo1 inhibitor. The data for sacituzumab govitecan comes from the Trophy U01 trial. This has multiple cohorts, 6 total. Cohort 1, 2, and 3 have been presented. Cohort 1, it was single agent monotherapy of sacituzumab govitecan after platinum-based chemotherapy and after immunotherapy. Many patients were heavily pretreated, had multiple prior therapies before getting SATC in cohort 1 of Trophy U01 trial. The response rate was 28% with longer follow-up, and median duration of response was about 7 months. Median PFS was 5.4 months. Toxicity was mainly bone marrow suppression and diarrhea, fatigue, alopecia, anorexia, taste changes. It's very important to use growth factor for patients getting SACI. So if you use sacituzumab govitecan, I always recommend a primary prophylaxis with growth factor from the beginning. The other point to make is that cohort 2 look at sacituzumab govitecan single agent monotherapy in patients who had prior checkpoint inhibitor and showed the 32% response rate with SACI alone as a second line after a checkpoint inhibitor. More recently, we saw that cohort 3, the combination of sacituzumab govitecan, SG plus pembrolizumab, was evaluated in the platinum refractory setting, second line, in patients who had early progression on platinum. And that showed the primary endpoint was met. The response rate was 41% with pembro plus SACI. This was a phase 2 trial. A median duration of response 11 months, median PFS around 5 months. So that trial, because it met the primary endpoint, it actually sets the foundation for a phase 3 trial looking at sacituzumab govitecan plus pembro combination versus SACI alone, sacituzumab govitecan monotherapy. And that phase 3 trial is ongoing in terms of the design in the cooperative groups. Is not open yet. Hopefully will open later in 2024. And we'll try to answer the big question about IO challenge. Patients who had prior immunotherapy, either adjuvant nivo or pembro EV or avelumab or pembro metastatic disease, if they have progression, is there value to re-challenge them with IO? So this SACI plus pembro versus SACI trial will try to answer that question. Overall, sacituzumab govitecan has accelerated approval by the FDA right now as monotherapy, and that's the only approval it has in urothelial cancer after platinum chemotherapy, after immunotherapy, and that accelerated approval is based on the cohort 1 that we discussed. There is an ongoing phase 3 trial that is the TROPiCS-04, and the TROPiCS-04 is comparing sacituzumab govitecan to taxane or vinflunine. So it reminds you of the THOR cohort 1, right, with erda, similar design. And that trial will report in the near future and will assess whether there is or not overall survival benefit with sacituzumab govitecan in that setting. For the moment, I think because we're still waiting for OS data from TROPiCS-04, I would say that in the sequence of therapies, Tian, if, for example, a patient gets pembro EV first line, I think, if they're still cisplatin fit, they may get gem-cis second line. If they're not, maybe carbogem. Erdafitinib is a reasonable option, either before or after platinum gemcitabine, and I will keep sacituzumab govitecan third or fourth line until we have OS data from TROPiCS-04 in terms of the sequence of potential therapies. A lot of information we covered, Tian. I just realized how much the field has been changing. You have been part of that, so thanks for all you're doing. And I would probably let you share with us your takeaways from our discussion today.
Sure. That sounds great. We've covered a lot, and absolutely we've done it together. I think the field has really changed since we started in it, and it's really wonderful to see these advances for our patients. So key takeaways, I think enfortumab vedotin and pembrolizumab is now approved and preferred for frontline treatment options for functionally fit patients who are well enough to receive them. Nivolumab with gemcitabine and cisplatin also now approved. Frontline velimab switch maintenance after platinum-based chemo, improved overall and progression-free survival. And then for patients who have FGFR altered tumors, erdafitinib is a good option. And then finally, sacituzumab govitecan is a later line option that's now FDA approved and still under investigation for additional roles. And these unanswered questions on multiple topics that I know you're actively working on, and the field hopefully will be made better because we're investing so much in the metastatic refractory spaces. And so with that, thank you all so much for joining us, and please complete the post polls in the tweets below or by using the QR code shown on the screen. And please don't forget to claim your free CME. Click the like and follow for more social media based CME from Bonum CE. Thanks, everybody.